I have fond memories and a lot of friends here. And I hope that today, after the presentation, the objective of every presentation is to learn something out of it. And I'm glad that I'm going to be able to use my experience from the past 8 years that I've worked in Cambodia. The malocclusions are very similar, so I'm sure that you can relate to these cases much better. Before I start, I always have a few slides. This is my wonderful family, my parents, my wife. This is the team that lets me go and do things that I do. Professor Kiểm, I did my PhD under him. That's my daughter and my wife. This is my son and my daughter again. My beagle. And this is from the Tweed course in Arizona. This is Jim Baden and Herbert Clons, who sadly passed away last year. And this is my master's supervisor, a very dear friend as well. And now are the three mentors who have molded me to who I am. I don't know if you recognize these people. The first, I'm sure everybody knows him. He's Bjorn Ludwig from Germany. The second is Dr. Ware, Nikhilesh Ware. And the third is Jay Bowman. They have inspired me with everything that they do for the profession to be who I am. I currently work at the University of Otago in New Zealand, and I'm an associate editor for these journals that you can see here. In today's presentation, I do not have any financial interest, arrangement, or affiliation with the products demonstrated. So I have no conflict of interest to declare. And with that, I'm going to start today's topic. Throughout the 2 days, I've noticed a lot of things in different presentations. And I think me and Dr. Lee are especially going to concentrate on this aspect. That's the vertical dimension. I believe that the vertical dimension is the most underestimated dimension of the three when we treat orthodontic cases. And I see so much value in over the years treating patients again and again. And I'm going to show you through cases what I have learned throughout these years. How many of you, and I'm going to make today's session very interactive, and I hope that's to just keep you awake, right, after lunch. I don't want you to sleep. So I'm going to ask you some questions, I'm going to ask you a few treatment options, and we're going to deal accordingly. So, how many of you know what this is? You know, this is the Dunning-Kruger effect. The Dunning-Kruger effect is so true in everything that we do in life. Do you see the X and Y axis showing confidence and expertise? You see, as soon as you graduate from your residency in orthodontics, we think we can conquer the world. We think we know everything. We can treat any class 2, class 3, whatever we see, because we have read about it, right? Probably we've done one case. And we think that every case is going to be a cakewalk, just like that one case. And so your confidence, as you can see, goes up. And then you start working in a private practice or in a university hospital or anywhere as an associate. And then you start seeing a lot of things going wrong in very simple cases, let alone complex cases. The things that you had learned are no longer working the way they should have worked, right? And so you start saying, I don't know how this works. Is this not happening? Why is this not happening? Why is the canine not coming back? Something is wrong. Why is the bite not closing? Because you don't have all answers. You thought you did, and so your confidence goes low. It goes low, 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 low. And so low that it hit rock bottom, and now you're like, I don't know anything. And then you start experiencing a lot of cases. You start with your experience, you start learning, you start a learning curve, learning from your own mistakes, going for different programs, looking at a lot of things that other doctors and experienced orthodontists do. And finally, you start getting success. And then you again rise up on your confidence. But now, with a lot of experience, right? So this is the Dunning-Kruger effect, and we all go through this. And today's lecture is again going to be on my learning curve. And the outline would be to start with is how I control the molars to start with in extraction cases, and what is the implication of that. How do I correct the curve of speed in different facial patterns? What about incisal and gingival display? We talk a lot about dummy smiles. And finally, counterclockwise or anti-clockwise rotation of the mandible, right? So all of this comes under the vertical dimension, and we're going to talk about it. So let's start with the vertical control of molars in extraction cases. I'm going to start with the first case I ever treated in my life. A girl, 23 years old, class 3 skeletal, spaced lower dentition, no habit, moderate to poor periodontal conditions on the lower arch. Her main complaint is lip protrusion and spaced dentition. What would you do? Raise your hands if you would extract something. Raise your hand if you would not extract. So the rest would just leave the patient? Okay, so I see non-extractions more. Now, maybe a viable option, but I believe that the lip protrusion may not be corrected with just a non-extraction approach. So, I extracted in this case. But, in my idea, when I looked at this case as my first case, I saw this case as a case that came like this. So this was just a sagittal issue, right? It was an AP problem, an anterior-posterior problem. So in my head, extracting 4 premolars and pushing the teeth back was the solution because the lips would come back, right? But then I never thought of many other things that would come in later, and I'm going to show you how. You can see the ceph, it's not much of a consequence in this particular case. Yeah, and the day one I extracted and we placed the tags because we were new at tags at that time. I wanted to place tags in all possible cases that I saw. I got an opportunity in, so I placed tags, and then I started pushing back. Now you see that I have bent the wire into a hook just to save some money, which was such a bad idea because this increased the flexibility of the wire and defeated the whole purpose of my retraction in the first place. But I didn't know all that. My goal was just to push the teeth back. And the lowers, even with poor periodontal support, not much of torque control, I decided to pull back. But now you will see that my lower incisors are just dumping and dumping and dumping and going back, right? I may have closed the spaces with maximum anchorage. Maximum because I have tags on the lower. I had no control of the vertical dimension. I had no idea where the molars went, what happened. My goal was just to close the space by pushing the lips back, right? And so I did. I finished the case. She was okay with the side profile. She said, yes, I'm very happy with what happened to the sides. But when you look at the ceph, I have made the face longer. Longer. You know why? Because when you have such mechanics, I'll tell you something that happens, and I want you to keep that in mind for the rest of the lecture. When you pull teeth back using a continuous arch wire, using molar as anchorage or tags as anchorage, and you do not control the molars, right? What tends to happen is that your teeth will come back. Your anteriors will come back to an extent. and then they start dumping back. Then they start extruding and retroclining. But not just that. Even the back teeth sometimes, because of poor sliding, has something called as the vertical bowing effect. The vertical bowing. And the molars tip mesially. When the molars tip mesially, the distal cusp of the molar extrudes. And now you have a transient opening of the bite, which has rotated the mandible downward and backward. Are you able to follow me? Okay. When the mandible moves downward and backward, what happens to the point B? The point B goes back. So I have made the class 2 a more severe skeletal class 2, but I have corrected the dentition. So I have just corrected the teeth, but made her skeleton worse class 2. Right? But I don't care about it, because I don't care about the vertical dimension as of now. Right? And so I finished the case. But I'll tell you a consequence. Evidence has suggested that in young women, especially, lip fullness is a very, very big determinant of youth. When laymen and dentists and orthodontists were compared to look at pictures, right? I want you to see the side profile. Looks okay. Looks okay. But tell me this. Does she look better? I think I have made her look at least 10 years older, because she has lost her mala prominence and lip sync. Her smile is of an old lady's smile, is what I believe. I think she smiled better in the beginning. Yes, she had protrusion, but I should have reached a middle ground. I should not have pulled her teeth completely back. Or even if I did, I should not have rotated the mandible downward and backward. So, this is the case number 1. I didn't know anything about it. I continued doing this for case number 100. And then I realized that most of my patients, some of them, nothing really happened. But some of them, I started taking superimpositions. I started doing superimpositions for all the cases. And I do it for all the cases, mind you. I realized that all my extraction cases, the lower anterior facial height has increased in class 2. And I'm wondering why. Then I look at the molar, and I see that the upper molar has extruded. And I'm like, why did the molar extrude? I was just pulling back. I use tabs, I use molars, but why did the molars extrude? Then I understood that that is the concept. When I went to tweed, I realized that you need to control the molars when you're pushing back, and I'll show you why. Young girl, 24 years old, same problem. I have protruded teeth, I don't like my lips, I want my lips to go back. But now, I'm case number 101. I know that I'm just not going to pull both her teeth up and down and pull it back, because that is going to make my skeleton worse. Maybe she's still going to look good, but I don't want my mandible to rotate downward and backward. I don't want to make her a more severe class 2, right? Just correct her teeth. So, the Steph, a typical class 1, maybe a class 2, protruded, bidental protrusion. Simple case, I think everybody would agree with extractions in this case, right? I don't think anybody would do IVR, whole arch, and pull back. So, okay. Yeah, so, yes. So now what I did in this particular case, please don't go into the biomechanics of why one side I used a longer tab. And again, some things you learn with experience, and that is why I'm showing you these cases. You know, I was stupid enough when I was young, everybody is, to feel that if, and she had a little cant, you see, so I in my head, with whatever biomechanics I knew at that particular time, say 7-8 years back, used to think, parallel force, we'll call it straight. This force will intrude and pull back, right? So I'm going to balance it. But then I realized that that is not what's going to happen. Retraction in this way is extrusive in nature because your forces are way below the center of resistance no matter where you're pulling it from. Unless you go to between the premolars, where the center of resistance of the actual maxilla is, or if you're retracting the canine to canine segment, high near the apex, distal to the canine. But in such cases, the forces of retraction are way below, right? So you're never going to get an intrusive vector unless you're really vertically pulling it up. In this case, it's still going to be extrusive. And I realized that during the case, and I stopped doing this. I just used two hooks of the same dimension and started pulling it. And the minor can't correct it itself with just bracket positioning. I didn't have to do much. But what I did differently is something that you can see on the molars. I always started tying a ligature or a power thread. I assume you know what a power thread or elastic thread is. From the tag to the base arch wire between the molar and the premolar. What does this do? Anyone? This does not let the molars come down. I'm not talking about active molar intrusion. I don't want to really intrude the molars here, right? Because I don't want to gain the rotation of the mandible. All I want is to not let the molars come down and extrude while I am pushing them back, because I don't want the mandible to rotate downward and backward, right? And obviously when I retract, I also add torque on the wire. Do you know why I add torque on the wire? You know, we use 22 slot brackets. So my retraction wire is a 19 by 25 stainless steel. 19 by 25 stainless steel on a 22 slot has a 3 mil difference, right? 3 mil difference is 15 degrees of torque loss, and the anteriors, the central incisors and the lateral incisors just have 17 or 14 degrees of torque. So I've lost it already if I don't torque the wire, right? Because it's just the slot of the play dimension. And if I retract, my teeth are going to dump. So to avoid that, I add labial crown torque on the wire. Yeah? But I didn't know the consequence of what happens when you add a labial crown torque on the wire. I just thought that it's going to keep my crown forward while I'm pushing it back. So I finished this case. She's happy. Look at the chin. I'll show you. You see the mentolabial sulcus? And I'm going to show you. I'm going to go back. Have a difference. Have a look at the chin position. Have a look at how relaxed the chin has become, right? Now, I did the superimposition. And in the superimpositions, I realized one thing. You know why superimpositions are important? Because they tell you what you do. Because you think you're doing something, but the superimpositions need to show that something has happened, right? Because you think you're intruding, extruding, and you've corrected an open bite by intruding the molars, but the reality of the situation is, when you superimpose, you will see that the incisors have all come down, right? So it's not what you think it is, and superimpositions are a good method to assess that. I noticed intrusion of incisors in this case, but that was not supposed to happen because all the mechanics was extrusive in nature. Why would I get this intrusion in the incisor? And I was like, I don't understand why I would get this incisor intrusion. And then I came across a paper by Hee-Jun Lee, who spoke yesterday, suggesting that in a two-vector force, if you torque the incisors, you eventually get an intrusive and retractive vector on the incisors. And that is why I got the incisors, because I always add torque on the wire, right? So I did that without knowing that this is going to happen. For another purpose, but that also helped me intrude and retract, right? So, similarly, I started using this more often and often and often. In adults, in young, in old. And now I had to treat a 49-year-old patient who came up with a very proclined jaw, lips. She had a missing molar, a long-standing missing molar, and she said that I don't like the appearance of my lips and my jaw. So we did the same thing, and I started realizing that this technique is more and more and more reproducible because I don't want the mandible to go downward and backward. I want to grow chin. So now, in every class 2 case, I start seeing the chin. The first thing I want to see is, does this patient have a chin or not? Because if the patient is high angle, right, she won't have a chin. And the mentolabial sulcus is going to be the mentalis muscle is going to be very, very hyperactive. They'll try to close the mouth like this, and you'll see the dots here. And incompetence of lips, right? But imagine when you rotate the mandible upward and forward, you reduce the lower anterior facial height, and the lips relax. But most importantly, what did you do? You got the point B slightly ahead, and you relaxed the class 2 skeletally, which makes it easier for you to dentally compensate it as well, because now your canines have come forward, your molars have also come forward, and now your class 2 is not as bad as a class 2 as it was in the beginning, right? So you can just retract a little bit, and you won't even make the patient look so old because you didn't retract too much, right? So win-win. Similar mechanics, closed. Incompetence corrected, smile line with gingival contouring, of course, and most importantly, the profile. So, I hope the first segment gave you clarity of what we do and how I have changed working on extraction cases with a class 2 component. And why is the vertical so important? So now, tell me, do you think a class 2 is just an AP issue? A class 2 is no longer just an AP issue for me. By AP I mean anterior-posterior, right? It's not just a sagittal problem. It's a vertical problem as well. If your mandible is rotated downward and backward, you will have a skeletal class 2, right? But that's also an increase in the FNA, the SNMPA, so that's a vertical issue. You need to correct the vertical dimension in order to get AP correction at the same time. It's not always just pull back, retract, pull back, retract, pull back. I do understand that you need to pull back a lot in many cases, right? But please assess the mandibular position as well while you do that, because that's going to make your patients look much better. A class 2 always will look better with a better chin, with a stronger chin. That's one way of correcting the class 2. Okay? Why do you use class 2 correctors? Why do you use twin blocks? The reason is you want to get the mandible forward, right? And if you're getting a very good chance of somehow getting the mandible rotated and forward using intrusive mechanics, why not do that? Right? You're not growing a mandible, you're just rotating it forward. Okay. Second component is going to be the curve of speed. How many of you know what curve of speed is? Raise your hand. I know what a curve of speed is. Do you know what a curve of speed is? So everybody knows what a curve of speed is. I want to see how many of you raise your hands now. What do you do to correct the curve of speed? What do you do to correct the curve of speed? So you know the patient has a deep curve of speed. What do you do about it? You just put a night eye. Simple, doctor. This is stupid, isn't it? I just put a night eye and the curve of speed would correct 3 months, 4 months, 5 months, I don't know, but it would become flat one at a particular point of time. So I don't really care, but I mean, why should I care about it, right? Now the question is, I was in the same bracket. I used to correct the curve of speed during leveling because it's a leveling issue, right? So leveling and alignment, leveling, obviously you need to level all the teeth together. I put out 012 night eye, 014 night eye, 016 night eye. By 016, by 022, it should be straight. And then now I reassess my case. Now, there are a few studies which have changed the way I look at curve of speeds now. And I'm going to show you how. This is a case of a 42-year-old patient with a very steep mandibular plane, residual ridges which were resorbed at the 6s because of a long-standing extraction. She had crowns on her upper anterior teeth, and she had a class 3 anterior crossbite. So she's a skeletal class 3, obviously, as you can see, but she didn't have much of an issue with anything. She was like, I just want teeth at the back. And I said, get implants, right? You're old, you don't have much of back teeth. Why would I close this space? You can just get an implant, you can do some IPR, probably just get your teeth back and call it a day. As simple as that. No, she's like, I don't have the money for an implant. I need those spaces closed. I will think of what to do with the back. I was like, okay, we'll think of that. But what would you do to correct the curve of speed on a high angle? Now, why I'm saying it, very important. Listen to this. I know you're sleepy, but then listen to this very, very carefully. I don't know if you know this lady. You know, her name is Paolo Posa. And she has done a lot of research on curve of speed. When you have a high-angled mandible or a high mandibular plane, increased FMA, right? Hyperdivergent facial pattern. Do you know how the muscle activity is in such patients? The pterygomasseteric sling, the buccinator, the masseter, they're very relaxed, hypotonic, loose, lax. Occlusal forces are very, very low. Teeth move very quickly in such patients. So when you place a curve of speed, when you have a curve of speed and you put a night eye inside, right, to flatten the curve of speed, because that's what we did, what do you think should happen? How do you want the curve of speed to flatten in a high angle? Lower, right? You want something to go up, you want something to go down. On a deep curve of speed on a high angle, do you want the molars and the premolars to go up and flatten the curve of speed? Because that is going to make the high angle even further high. You want the incisors to intrude, right? But let me tell you, and break your bubble, that is never going to happen. Because the muscles are so lax that the premolars extrude by 3 to 4 millimeters on an average, and the molars extrude 2 millimeters on an average. And you all know the scissors effect, right? If you open a little bit at the back, what happens in the front? It opens quite a bit in the front. Imagine 2 millimeters of molar opening, just like that. And you don't even care about it because it's leveling alignment phase, right? You took Ceph in the beginning and you're leveling. Who takes a Ceph after to see what happened during leveling? Nobody. So, you have increased the vertical dimension already. And you don't know about it because you didn't care about it. You just put in a wire, right? So, on the contrary, if it's a low angle, brachycephalic patient, hypodivergent, the muscles are too strong. Occlusal forces are known to be the highest. Bite forces are highest. Pterygomasseteric sling is too strong. And no matter what you do, you put the curve of speed, you put a flat wire, what do you want? On a hypodivergent, you want the molars and premolars to extrude, right? But do you think that happens on a low angle? No matter how much you pull it up, they're going to go down. You pull it up, in 3 months, you'll have a deep bite again. The muscles are so strong in hypodivergent brachycephalic patients. So, you want the molars to come up, premolar to come up, that's not going to happen. How the curve speed flattens is by proclination of incisors. We know that the symphysis is denser in hypodivergent cases. So it's okay to procline the incisors a little bit, but that doesn't mean you really procline and flare them too much, right? So that's how it happens. And with that, let's keep in mind, let's go back to this case. I need mechanics to flatten the curve of speed in this case, but without extruding the molars. So I need to think. And I come up with this strategy. I'm going to put bite turbos on the molars. Putting bite turbos on the molars, my molars are not going to extrude anymore because the bite is going to stop the molars from extruding, right? But still, the premolars, as studies suggested, could extrude 3-4 millimeters. So now I put a tad right between the premolars, which is not a very easy position to put a tad down. and use a ligature from the tag going up to the base arch wire. Now that does not let my premolars extrude. And now what's going to happen? Now my incisors, all the forces are going to act on my incisors. So now either my incisors are going to flare or going to intrude. Intrusion without any force vector is almost impossible in the incisor region. So what I do is I use a small retractive force from the tag onto the hook between the wire to direct the force this way. So now I have the niti flaring it out, and I have a slight intrusive, which results in more of an intrusive force. Still may not be completely intrusive, but it's not going to be as bad, and it's not going to flare out too much. So now my purpose is solved. And space closure obviously is going to be through mechanics. As you can see over here, it's a 1925 stainless steel. I have a tip back bend, which is closer to the alpha segment, that is closer to the premolars, which increases the alpha moment there. So when I place the wire in, here, when you see the wire is going in first. When I place the wire, obviously I place it on the buckle tube. So the wire is going to go straight and then down here. And when I pull it up, it thrusts all my premolars forward, increasing the anchorage. And then I use a light displacement or protraction force to close that. The key to closing spaces on a knife edge, again, it's not something that is reproducible again and again, because knife edges, you can hardly move teeth within the knife edge because there's not much of a bone. But then I experimented in a few cases with Dr. Bertie Melson's theory of moving the roots. She says, walk the roots in the bone first. So you move the roots first and you have some amount of bone remodeling. And then you again tip. Move, tip. So you grow bone, move the crown. Grow bone, move the crown. And that's how you can get some amount of success in certain amount of cases. Eventually, I was able to close this space, as you can see over here, but luckily, I was able to close the entire space of, say, 10 millimeters. Stability, big question. We followed her up for 2 years. Profile didn't change much. You can see that the molars have tipped distally and not mesially tipped, which is the major worry in such cases. You have the molars which tip mesially, but fortunately they tipped distally. There's no coverage for the second molar, but we had a vacuum formed retainer with a distal pontic because she didn't want it. She didn't want an implant, so I didn't have much of an option at that particular point. 2 years later, there is black triangles. That means that the bone is resorbing a little bit, obviously, because when you camouflage a class 3, you have to be under the, you have to know that there is going to be some amount of bone loss, because, I mean, it's not natural. You are moving the crowns back, the roots come forward, you're going to lose some amount of bone there. Expect that amount of bone resorption or vertical bone loss, which would lead to some amount of gingival recession, which would in turn lead to black triangles, right? So if you inform the patients, many issues can be solved. Look at the superimposition, note the amount of molar movement. And I've written a detailed review of molar protraction in orthodontic waves. And when we see this picture of a camera, click a picture, I think you're going to enjoy reading this review as well as this case report. Now, let's go to the immediate after. A very low angle class 3. A very low angle class 3 with a deep curve of speed, right? Can you imagine if I place a niti wire on this particular patient, in the beginning what's going to happen? As we mentioned, on a low angle, I would want the premolars and the molars to extrude, right? That's not going to happen in this case. The muscles are just too strong. I need the lower incisors, right? The incisors in this particular case to probably stay where they are, extrude the molars, but unfortunately the lower incisors are going to flare forward, right? And that's exactly what I don't want in this case, because that would become a surgical case class 3, which would definitely need surgery at some particular point. Then, so how do I mitigate that effect? What I do is I place lingual bite turbos on the lower anterior region in such a case, which would open the bite, and now the bite force or the force of occlusion, which is already very strong in a hypodivergent case, is hitting behind the center of resistance and will not let my lower incisors go forward. See, the bite is this way. The inclination of the incisors is already retroclined. Bite is like this. It can't just go forward easily. But that also transiently opens the bite at the back. I used elastics. I force extruded his premolars up. But you won't believe, and I'm not joking, I took at least 1 year to extrude his incisors up, because in 2 months I was able to extrude the premolars up, but the third month it goes down again, and then I again push it up, then it again goes down. But one thing I noticed, if I put it up 100%, it goes down to 70%. It doesn't go down 100%. So doing that repeatedly for 3 cycles, I finally got some 50% of extrusion up, which was something that I was okay with. But curve of speed correction needs space, right? You can't just flatten a curve of speed and say that my incisors are going to stay exactly where they are. How is it going to flatten? The teeth are going to go somewhere, isn't it? So in this case, I decided to place buccal shelf implants and distalize the teeth back at the same time. So you can see the buccal shelves placed, and I'm distalizing on a 1925 stainless steel. Slowly and steadily, distalization is happening, and we were able to reach a stable conclusion. So, he's okay. I took about more than 2.5 years to finish this case. And we had the superimpositions which show lingual tipping. And at the same time, a decent change in the smile line, profile. Now, very recently, we've started working on Botox. Botox as a method of relaxing the muscle activity in hypodivergent cases. Right? Botox usually it deactivates these strong muscles, giving you some time to play with the mechanics you want. They active for say about 12 weeks, 2 to 2.5 units, and you need to repeat them. And which gives you some amount of easier tooth movement, not necessarily stable. Dr. Liawu here has recently published a paper in the World Federation of Orthodontic Journal, again showing how on low angle cases he uses a beautiful technique over here, as you can see, in which he uses a spring from an implant to extrude the teeth down, right? And to increase the vertical dimension, he has a posterior turbo which increases the vertical dimension, creates a space, and pushes all the teeth down. That's a very, very nice way of extruding and increasing the vertical dimension in such cases. Now, getting on to the third, which is incisor and gingival display, which is a very in thing these days. People love correcting gummy smiles nowadays, right? So we see a lot of gummy smiles. We've started seeing more gummy smiles than before, and we want to treat them as soon as possible. And I'm going to show you a few cases in which how we were able to put down objectives on certain cases and treat them. So there are some class 2 cases with vertical maxillary excess or with passive eruption, many reasons for gummy smiles, right? And when you have, and with age, by the way, your gummy smile reduces. As you grow older, everything goes down. Your lips go down, and you start showing more of your lower incisors, your upper incisal display reduces, obviously your gummy smile also reduces. But a patient comes to you at the age of 20, can you say that, don't worry, I'm not going to treat you because at the age of 40 you're going to be looking okay? Can you say that? You cannot go telling a patient that after 20 years you're going to look better, right? Because the patient is going to be like, I want to look better now, and not after 20 years. And then you have to treat them. But then you have to tell them that maybe after 10 years you're going to start looking older. Don't come back to me because I can't do much at that particular point. So that's the realities of orthodontics, and we have to get used to it. We can't correct everything. There are some things which stay good, some things which change transiently. Old patient, 53 years old, came up to me. She said, I have proclined teeth, I can't close my mouth, I have a severe gummy smile, I don't like my gums. Corrected. So, when I looked at her, there are two ways of reading this. You can either say, why do you need to correct it? Or you accept the fact that she really wants to look good and you correct it, right? If this was a 20-year-old girl, would you correct the gummy smile 100%? With zero gum display. If this was a 20-year-old. In cases with a 20-year-old or a very young patient, I would not. I would leave 2 or 3 millimeters of gums. You know, it looks youthful. It looks youthful. But if the patient really doesn't like gums, you have to treat it all the way. I mean, that's a different story. But on a 53-year-old, I'm not going to leave any gum if I treat it. Because she's not going to grow again into a not gummy smile. Yeah? So she's already 53. So I need to correct it 100%. She has a scissor bite on the right side, which makes things horribly hard. Scissor bites are hard to correct. And unfortunately, they need to be corrected before you can do anything else. You cannot progress with a treatment without correcting a scissor bite, right? So, I don't know if you've noticed this. Patients with more severe malocclusion are very, very compliant. Because they come to you for treatment. They really want to get treated. So they are somehow more compliant than the others who the parents just push that please treat him and get the braces on him. They're not compliant. She was compliant. And what I decided was first we need to assess where is the problem. There is some amount of extrusion on the upper left side, but also the lower arch is very narrow. Right? So we have to kind of upright the posterior teeth on the lower arch. And I don't know, you can either place brackets, but I chose to use the Schwartz appliance. So a Schwartz appliance is a removable appliance which uprights the lower posterior teeth, and at the same time it provides a bite turbo effect which opens the bite and gives you the clearance on the scissor bite side. Because to correct a scissor bite you need clearance, right? You need to open the bite. So what better than having an equal bite on both sides? Because the only other way I know is raising the bite on one side. So big to clear the bite over here. But this gives you an equal bite on both sides, right? I don't know much about the TMJ, but I'm sure that this is much better than having a big, huge bite turbo on just one side. Now, as you can see, after 2 months of activation, one turn every other day, because there's no suture on the mandible. You don't want to really push it far. What happened is, slowly and steadily, I see that the scissor bite is corrected, and the other side goes into a cross bite because that side was normal. So what I do is I just let the other side relapse, and the side that had a scissor bite, I hold it with cross bite elastics, right? For 2 months, I hold it there, and finally, 3 months, and then once it's kind of stable, I bond brackets, and I use copper nitrile wires which are slightly widened, just to maintain that effect so that I don't want them to just collapse again. Now my next objective, I've corrected the scissor bite, right? Now I have to correct the proclination and the gummy smile. Time to extract. Extraction, go in 3 tags between the premolar molars, and in the central. I would love to place 2 tags in the front. I know Dr. Liao does it. I prefer placing 2 tags over here to correct an active gummy smile. She said, no, I don't want it. And I'll tell you why. The reason is very funny. I'm treating her daughter as well, who has the same gummy smile, and I place 2 tags on her. If you have placed 2 tags with very long hooks, you will realize when the patient smiles too much, sometimes the lips get stuck on the tags, like this. And they can't close the lips back. So in a party, probably she smiled too much and the lips got stuck. So every time she gets stuck, she has to pull it out of the chin. It's a very funny thing, and she's like, no, I don't want that. I will not have that. So please just place 1. I was like, yeah, with 1, maybe the chances of that happening is slightly lesser, but I can't guarantee it's going to happen. But anyways, placed it and started retracting, closing the spaces. Was not very easy closing spaces. It took a lot of time on how to close spaces. I had some bending, then I had to correct and all those things again and again. And finally, has anyone seen something like this happening? You know, this is called alveolar bone exostosis. And I've done some research in it, and I find that in cases with the tori, this happens a lot with intrusive forces or heavy forces of retraction. I don't know why it happens. There are many reasons that have been postulated, but it does happen in most of these cases. It doesn't spontaneously always regress. Sometimes it does. But if it's this severe, you have to raise the flap. Use a carbide burr, shave everything off, put it back. And while you're at it, also do a gum contouring. Because when you intrude, your crown becomes smaller. The gums will not always go up at the same level as the crown will, right? So you will have to cut the gums. Sometimes you will also have to do a crown lengthening at the same time. But if you're raising the flap, it's easy. You anyways are raising it, so do everything in one go. That's what I did. And did a gum contouring, as you can see, gingival contouring, recontouring, whatever you want to call it. And at the end of the day, we finished her. Obviously, she was happy. We got the tooth and the bone where it was supposed to be. Good correction of the scissor bite, good correction of the class 2, good correction of the intrusive effects. But importantly, you can see the change in the lower anterior facial height, right? Now, after 300 cases probably, I started to realize that orthodontics can also make people look younger and not always older. Because in the beginning, I used to make them look older, right? So, controlling the vertical dimension or just a thought process can make the patient look younger and older. It's reality, right? I showed you a 53-year-old. I'm going to show you the same with a 23-year-old again. She says, I don't like my gums. Short, moderate to short clinical crowns, full class 2. But now all I see in a class 2 is the chin. And I'm looking at her and I'm saying she doesn't have a chin. I need to get her a chin. And that is how I'm going to correct her class 2. I'm not going to push her teeth back. She's incompetent. I can see the mentalis strain. I know I have to retract. But I also need to get the chin upward and forward, which is going to relax the lips over here, which is going to correct her skeletally and not just dentally. Right? So she has a very severe gummy smile, I think 8 millimeters or gummy smile. Look at the Seth, biprotrusive, high angled mandible, rotated mandible. And now this was a small experiment. I sometimes just like experimenting on cases. I know it sounds bad, but then I just do it. Because I see a lot of cases on social media in which you intrude without extracting. And I know that intrusion is protrusive in nature. You'll always protrude your teeth when you intrude teeth, right? Because intrusion needs space. And I was like, can I maybe torque the brackets or wire and see if it's gonna hold and not procline the teeth? But unfortunately, it didn't happen. In this case, I added a lot of lingual crown torque and intruded, but still you can see all the teeth started flaring, right? It didn't help. Anyways, I had to extract. And so, at this particular stage, you can see I created an open bite by intruding without extracting. So I just flared out everything. All the teeth are flared out, right? But at least I had an extraction plan. I placed a TPA. I usually give 7 millimeters of a clearance. Now the rationale behind it is, do you know how many times you swallow in a day? We swallow about 800 to 1,000 times a day. And every swallow, we deliver about 500 grams of force, right? So the tongue, if presses against the palate, gives you about 500 grams of force. Now fortunately, unfortunately rather, there's no evidence suggesting that highly placed TPA is going to intrude your molars. It's anecdotal, but it's definitely going to hold your vertical position of the molars. And that's why it's also called a vertical holding appliance, or a VHA. So, I placed 4 tabs. 2 premolars between the premolar molars and 2 between the lateral incisors and the central incisors, and now I start intruding again with extractions, right? Now, it makes it way easier. I'm intruding, intrusion causes flaring, but my retractive forces counter that, and I'm able to get good amount of intrusion and retraction. Simple logic. And from the palate, I hope that the tongue keeps pushing it forward. Now, slowly and steadily, I want to ask you this question. When my incisors and molars and everything in the upper arch is going up, right? Should I see an open bite? It's $1 million question. Should you see an open bite? Technically, I'm pushing everything up, right? So I should see an open bite, because do you think the molars and the incisors go up at the same rate? Molars have so many roots. Incisors have one. Why should they move at the same level? Why should they move at the same time? Right? Ideally, they should not. Something will move fast, something will move slow. So, I was under the impression that the molars will go up and the mandible will rotate upward and forward, and I will never see an open bite. But the second month and third month, I started looking at this huge open bite. And now I feel that something is wrong. I am not supposed to see this open bite, but I see an open bite. That means something is not working properly. Then I realized that I was a fool to not bond the second molars, and I bonded the uppers, and the lower molars were passively extruding into that space when I was intruding the uppers. So I never get clearance on the posteriors, right? And if I don't have clearance on the posteriors, I will never see counterclockwise rotation of the mandible. And so now, I place tads on the lower arch. You see the tads here on the lower arch? And now I have a power chain from the lower tad onto the base arch wire, which is going to hold the lower molars where it is, and not let the lower molars erupt. And now when I intrude the entire upper arch, the open bite vanished. That means I have obviously retracted, at the same time gained a lot of counterclockwise rotation, and I'll show you how. At this particular point, the last panel, I needed some class 2 correction, but obviously if I just use class 2 elastics, I'm going to extrude the incisors again. So I'm holding them with some ligature ties so that they don't extrude back, the incisors don't extrude, and I just get class 2 correction. I do some gum contouring, right? Gum contouring is important, and don't let anyone tell you when they're correcting gums, they don't contour the gums. Obviously, it's a very important part. You have to recontour the gums for a better aesthetic profile, or else you're going to have very, very small crowns and too much of gums again. You can see the amount of intrusion that I have achieved in this particular case, and she's happy. More importantly, I am happy because I see the Steph, and I'm going to show you why. You see the relaxed lower chin? Do you see the chin in her post? That is what I want. I want to grow a chin, and that is possible only if I move the mandible upward and forward. Otherwise, I will not get that in this particular case. And that is how I was able to correct this class 2 far better than just by pushing teeth back. That's about it. Yeah. You see this? This is the chin that I'm talking about. Now, we've written a paper recently on gummy smiles, etiologies, diagnosis, and formulating a clinically effective treatment protocol. I would suggest all of you to read this, because this is going to give you a good amount of insight on gummy smiles, right? So, coming on to, I think I have 2 more cases after this. Yeah, so, young girl, same mentalis strain, incompetent lips, gummy smile, protrusive lips, right? Very similar to the last one, but there's a difference in her. She was a transfer case. She was a transfer case, and when she presented to me, she presented like this. Extractions of the upper and lower premolars were done. Canines are still full class 2. Bite is even more deep. Iatrogenic. A lot of iatrogenic effects in this particular case. I have lost all anchorage, but I have more importantly lost premolars in this particular case. And now I don't have the privilege of extracting a premolar and pushing her dentition back and up anymore. So now, there's already some interradicular tabs placed over here, but I don't think they're going to help. So I changed the mechanics, and I don't know how many of you know Professor Almeida. He's a master when it comes to extra-alveolar tags. I remove the posterior tags and change the position, and I place it in the infrazygomatic crest. That is the longer implant. They're the 12mm implants, and then they're longer. And now they give you clearance from the teeth. So you don't, when you retract, the implant doesn't come in between anymore, because these tags, especially the back ones, they're not between the roots. They're high up. Yeah? And at the same time, you intrude. So you intrude, and now you place IZC at the back and let that happen. And when you let that happen, after a year, this is what happens. Your crowns become smaller because you have retracted a lot and you have intruded a lot. So you will need to do a gum contouring, right? Or the patients will say that I came with a gummy smile, you made me even more gummy at the end. So after gum contouring, you get a much better aesthetic result. You see that the lower incisors are positioned better, you see the superimposition show a good amount of intrusion, and then more importantly, you see a good profile. You see a good change in the competence of the lips, and then you see a good smile. Right? So this has to be the end goal of treatment. And now, we spoke a lot about class 2. Let's talk about one case of class 3. When you have a class 3, you never have incisal display in many, many cases. Your upper incisals don't show much. Patient doesn't even know how to smile. You ask a class 3 patient to smile, they would never smile. They'll do everything, but they won't smile. And then you have to make them smile. And I asked her to smile, and this is how she smiles. I mean, you can't expect her to smile because she doesn't show her teeth. She's not confident smiling, right? Her main problem is not her bite. She's okay with chewing. She can chew very well. She can do everything. Her main problem is that she is not able to smile. She said, I want to smile. I can chew, I can eat, I can do everything. I just want to smile properly. Can you make me smile? And I'm like, this looks like an easy case, but I don't know if you can still smile after. I can correct the class 3, but I can't guarantee if you can smile after. So I need to extrude my incisors in some way. And I'm thinking, so how many of you, for you, is this an extraction case? Raise your hand. Non-extraction for all of you? Wonderful. I can't do this non-extraction. So when I see premolars, I feel like extracting them all the time. No, I'm just kidding. But then, yes, this case, I extracted the lower first premolar. Only. But, follow me on the mechanics, right? She has a decent facial height. She has a normal to okay lower anterior facial height. But, have a look at this. The set is absolutely okay. I don't see much of an issue with this, right? So the mechanics I do is something like this. I extract the lower premolars. Now everybody, you need to understand this with me. Now, I extract the lower premolars. In such a case, it is very easy to jump the bite. To retract and get a positive overjet is very easy. You do not need to actually extract a premolar and use 5-6 millimeters of space. No, you can easily retract. And just maybe 2 millimeters of retraction is going to jump the bite in this case. But the key is, how are you going to control the vertical dimension in this case, right? So what I do is, I raise the bite, because you need to raise the bite, right? In order to retract it. So I raise the bite posteriorly on the molars and the premolars. But on the premolars, look at the bite turbo. The angulation of the bite turbo is such that it provides anchorage on the lower arch, right? So I use a power chain. and I obviously have torque incorporated in the lower incisors because I don't want to dump them while I'm retracting them, and I get the lower incisors back. So I got a positive overjet, right? I still have a lot of space at the back. Yep. Now what I do is I trim the bite turbos from the molars only. I leave the bite turbo on the premolar. Okay? So can you imagine now it's like a tripod? The bite turbo is only on the premolar, and my molar is open and my anteriors are open. So it's like a tripod effect, right? The fulcrum is only at the premolars. Now I use a heavy arch wire on the upper, which is a 1925 stainless steel, ligate it and make it a unit, and now I will use class 2 elastics. Can you imagine what's going to happen? Because it's a fulcrum, the upper arch will try to swing this way. The upper arch is going to swing, and it's not going to create a dual occlusal plane because I have ligated the entire upper arch, right? So it's a unit. So the entire upper arch is going to move this way with heavy class 2 elastics. What is the class 2 elastics going to do to the molar? It's going to extrude and close that space because I have an open bite there, right? Because I just trimmed the bite turbo. So it's going to extrude and close that space. At the same time, obviously your premolars are also going to go forward a little bit. But you still have the gap there. And at the end, you can just trim that bite turbo of the premolars and use up and down elastic, 1/8 elastics, and just close that space. But what do you think you did? You have now rotated the entire upper occlusal plane clockwise, downward, increasing the incisal show by not individually extruding them in any particular way, right? So, during the treatment, obviously I could see the smile and I could see more of an incisal show, which got me more confident in what I was doing. And in the end, I was able to achieve a wonderful smile. So you can see the lower anterior facial height has increased a little bit, obviously because of downward and backward movement, which is good in a class 3, by the way, which is not a very good thing in a class 2, not a good thing in a class 3. And you can see the relaxation of the lips. But the best part is 100% change in the smile line. A 100% change, right? From an absolute lower to an absolute upper incisal display. And I think this is what her main issue was. She wanted to smile better, right? Obviously we can correct a class 3, but getting a smile is not very easy. Dr. Liang again has published a paper very recently in the Angle Orthodontist, which shows you extrusive mechanics, which I believe can be very, very, very useful in class 3 cases with low incisal display. If you look at it, this is exactly how he extrudes the incisors, and in fact in this case it's the whole arch, but we could always replicate this in the incisor region. Also, we have discussed this greatly in our paper titled The Tag-Driven Class 3 Camouflage, 8-point protocol to optimize efficiency, aesthetics, and stability. Now, coming to the last, and this case actually has a story, and Dr. Ronnie in the previous lecture was talking very interestingly about how we need to take care of our patients and such things. I do believe it is very important to look at it, but then you see, I was always the kind of an orthodontist who never spoke much with the patients. I never had that tempo with my patients. I used to just treat them like a patient, just treat them and talk as less as possible, because that kind of somehow gave me the satisfaction, and I kind of scared them a little bit at the same time. But it worked for me. And I never used to consider the psychology and the impact of psychology on orthodontics. Which brings me to the hardest case that I have ever treated in my life. She is, I think she's 24, 25 years old. I even forgotten the age. And she came to me and she said, she came with a mother, in fact, and she didn't speak. She just wouldn't speak. And she had incompetent lips. I took pictures. I saw a slight gummy smile, and I saw this hugely protruded lips, right? And I thought this was just the other regular case that I treated, right? It's not very complicated. And then her mother always told me that, please, she's going to be a little difficult. And I never understood why. And I never bothered asking her why. So I never did. And she was like, yeah, she's bullied in school. She was bullied in school. And then I was like, yeah, bullying, yes, probably because of the face. A lot of patients come to me, they say I'm bullied. So I was like, okay, maybe she's also bullied because of her face. And so we will treat her, she's going to be okay. But I never considered the impact of bullying on her psychology, right? When I looked inside, and you will see why this is the hardest case that I've treated in my life. Her incisors are very procline. She has an absolute scissor bite in her upper left quadrant, as you will see. You can clearly see the lower left dumped lingually. Extremely flared incisors, crowns on her incisors. And a very, very steep mandible plane. Her FMA was 42.3. But what I want you to understand is, do you think this FMA is the true FMA? With an FMA of a 43, it's a skeletal open bite. Where is the open bite? Do you see the scissor bite? Yeah? The scissor bite is camouflaging the open bite. If you correct the scissor bite, do you think you will be able to maintain that FMA? It will rotate further downward and backward. Yeah, you can try to not extrude it, but obviously there will be contact between teeth. And when there is contact between teeth, your mandible is going to go downward and backward. This chin that she doesn't have is going to further go back. And you know, she told me, her mother told me that she was bullied with that meme. Do you know that meme with a donkey smiling? It's a meme with the donkey smiling. It's a GIF where the donkey has all flat teeth and they smile, right? So she said that she used to always be bullied with that particular thing. Anyways, let's go back. And I want all of you to discuss this case with me, right? We see a hugely high mandibular plane angle, flat, proclined lower incisors, mesially tipped molars, low bone levels, deteriorated, degraded molars or mutilated molars, root canal treatment on the incisors and crowns on the incisors, and a premolar on the lower left, which has a very small root to begin with. But that's the least of my concern as of now. I have to think of what should I do to correct this particular case. Option 1, surgery, right? Because obviously, you can do, because this is a very severe case otherwise. So you need to think of surgical as an option. But if I do it orthodontically, I have to make my objectives very, very clear. Objectives. Correction of the lip profile. I have to correct her lips because that is her chief complaint, right? I know that the gummy smile she has is not, it may be a component of a vertical maxillary excess, but it is primarily because of her flared teeth. When you have very proclined teeth, your lips tend to tract more when you smile. Have you noticed? So when your teeth are really flared, and your lips, when you smile, will fall on the teeth, right? So if you're flared, they will retract much more up, and then you'll have a more gummy smile. Sometimes when you just retract your teeth and upright your incisors, your gummy smile relaxes much better. Okay? So I was not very concerned with her gummy smile because I knew that if I retract her teeth, her gummy smile is going to be corrected. My major concern is how to get her chin. I have to get her chin because I'm not going to just pull her teeth and push it back. That's going to make her worse. It's going to make her like a retrusive bird-faced mandible, right? Like one of Dr. Hans' case, he showed microsomium, that kind of a case. I don't want that. So now, and reduce gummy smile, which is secondary to the proclination. How do I correct the scissor bite? As I mentioned, there are only two ways I know. One is either you intrude using IZCs and pull up and correct it, or you raise the bite on one side. So I did. I raised the bite on the right side so much. You know why? Because my scissor bite was on the second and third molar region. And when you have a scissor bite on the second and third molar region, you have to open the bite so much. I think I opened the bite, say 10 millimeters on one. Now, I use the buccal shelf, as you can see over here. There, I place lingual buttons on the lingual aspect of the molars, and I swing out teeth through the occlusal surface. When I do that, I reduce the extrusive component. I reduce the extrusive component of the molars because I don't want the molars to extrude while I correct the scissor bite. Yes or no? Everybody agree? Very sleepy? Are you able to follow what I'm saying?
Yes.
Okay. So, I raise the bite on one side, I place a buccal shelf on the other side, and I swing the molars to this side, right? So this should correct my my scissor bite. But now, this will end up in an open bite, as you can see over here. And this is the actual skeletal open bite that we should have seen without the scissor bite. Do you know, if I could have probably taken a set at this particular point, my FMA would have been 15. I reckon. But I did not. It started with 42.5, but now it should have been about that much. But what I want you to notice here, at this particular point, is what is the overjet? The overjet is, say, 8 millimeters? 7 or 8 millimeters of an overjet is what I think it should be at this particular stage. Now, I think that now I have a class 2, I have an open bite, and I have an increased overjet, I don't have a chin. This is the time I need to now get the rotation. Right? So now I want to get the rotation. So what do I do to get the rotation? I intrude the molars now. Right? And now you will see, notice this overjet. And notice the overjet in the first stage. This is after 4 or 5 months of intrusion. You can see that I've extracted the upper premolar, but the spaces have not closed yet. This is the day I extracted the premolars. But do you notice the overjet? Look at it again. Overjet 8 millimeters, overjet 4 millimeters. How did that happen? How did that happen? The mandible rotated upward and forward to reduce the overjet. I haven't retracted anything yet, right? So now, I'm confident that I am able to rotate the mandible upward and forward, and now I'm going to push the upper teeth back, right? So now I use the same IZC that I placed up, push back. You can see I've used a TPA with again the same clearance of 7 millimeters that I usually standardly use, and start retracting the teeth. So when I start retracting the teeth, my upper incisors dump. Now I did that on purpose, especially when you use these Damon brackets, right? They have too much of play between the bracket slot and the wire dimension. It's very difficult to control torque. And you will literally dump your teeth. So I didn't bother with it much because her incisors were flared. I was okay with dumping the teeth back. But on the lower arch, I had to start closing the spaces of the molars, right? So now I place buccal shelf implants, and then I start retracting the teeth lower arch. So you can see buccal shelf implants on both sides, and now it's a very easy case, right? So I have corrected my objectives of scissor bite, of counterclockwise rotation of the mandible, and now all I have is simple space closure to be done, right? At one particular point of time, what happens is the upper teeth dump too much, right? And remember, I said she has a gummy smile, right? She still had a little bit of a gummy smile, but her teeth looked too dumped. So I told her that I'm going to place a tag. She said, no tag. I don't want a tag anymore. So then I had to think of something else, and I thought of a simple intrusion arch. Now this is a 17 by 25 TMA arch wire with a tip back. You see tip back? You can't see the tip back obviously. There is a tip back on the molars which will push the incisors, the component up. You push it down, tie it between the central incisors, and obviously you have an extrusive component on the molars which is countered by the TPA that you see over here. I use the TPA, right? So that's not going to let the molars extrude. That's just going to not really intrude my incisors, but it's going to give you a counterclockwise movement of the incisors, right? Finally, after a lot of this thing, a lot of retraction, again I saw ABE, alveolar bone exhaustosis, right? So I reflected the flap, used the carbide burr, trimmed everything, and while I was at it, crown gum contouring, because you need to contour the gums. You need to really contour them to get a good smile aesthetics. And finally, some small space closure, midline correction, easy part. I'm not going to get into this, but then the concept of the lecture today was to correct the vertical dimension, right? And finally, after 34 months of treatment, we end up in a full class 2 molar, which was expected, obviously, but with a good incisal display. And more importantly, you can see the scissor bite corrected, the incisal positions corrected, and you can see the set. You can see a good mesial movement of the molars, no bone loss, no further. The premolar is still hanging in there, and then you can see the comparison of the OPG in both these cases. This was a very, very hard case for me to treat per se, but then I'm lucky that it worked out in the end, and you can see the change in the set. Do not think that I have retracted the lower incisors too much. This is a concept I was discussing with Dr. Leah right in the morning, that you see her lower incisors are too flared. You know, that is because her mandibular plane is too high. Can you imagine her mandibular plane rotating like this? Her incisors are not more upright anymore. So you don't really need to pull the incisors back that much. Me rotating the mandible upward and forward has corrected the IMPA considerably already. So that is a concept which I need all of you to understand. But finally, you can see the amount of retraction and the intrusion and the uprighting and the counterclockwise rotation of the mandible as a result of intrusion of the upper molars. Now I guess people can't make fun of her with that meme anymore, because we have corrected her. But till now I did not understand the effect of psychology. She came back after 2 years. I saw her, she was very stable. And why wouldn't she be stable? Because we followed all the mechanics of ideal orthodontic principles. There is no reason she should be unstable, right? What gave me goosebumps was this letter that I received from the patient's mother. Dear Dr. Adit, thank you for making my daughter smile again. The first time we met, I remember telling you how she had tried to commit suicide twice because of her face. You know, the worst part is I don't even remember that, because I was such a bad communicator. We didn't have the money for surgery or nor support, but you gave us hope. The past 3 years were tough, but now I see another person in her. I have never seen this side of her. She talks about wanting to go to college, and more importantly, she wants to live. Thank you for saving our daughter. Thank you for giving her a new life. What you've done is priceless. So every time I read this letter, I get goosebumps myself. No, seriously. And this makes me feel that we are not just dentists, we are doctors, right? And we save lives. And from then onwards, I started taking the psychology of the patient and started talking to patients more to understand the background that they're coming from. And you just can't be a doctor. who treats teeth, right? Because it's much more important. Some things are very important. Some things are more important than teeth, right? Sometimes you don't even need to treat the patient. You can just talk them out of it, and they will believe what you say. So, as Dr. Ronnie was saying, we need to be better doctors. We need to be better communicators at the same time. You want to read this case in detail. We published this in the JCO, non-surgical management of severe atypical class 2 using mini screw anchorage, transparallel arches, and an intrusion arch. Take a picture of this. Follow me on Instagram. That's what everybody says. You will see a lot of cases. You will see sort of things, and I'll get more followers. I might make money.